Hello everyone, my name is Ala Sayed. I'm a fourth year medical student at King Saud bin Abdulaziz University for Health Sciences, and today I'm going to talk to you about strokes. Now before you watch this video, I would recommend you watch our other video about blood supply of the spinal cord and brain, and also watch our first video about strokes. Our talk today will include the differential diagnosis of stroke, how to diagnose a stroke, and how to manage a stroke. The differential diagnosis of stroke actually include migraines, and especially the aura phase of the migraine. Now, in the aura phase of the migraine, the patient might get motor or sensory symptoms similar to those in strokes, but the only difference is that those symptoms actually do not happen acutely like they happen in strokes. So in migraines, the sensory or the motor deficit will actually migrate through the limb over minutes rather than seconds in a stroke. Another differential diagnosis is seizures. Now, after the seizure is completed, there's a phenomenon known as Todd's paralysis, in which the patient that had a seizure cannot move. Now, the thing is, here comes the role of good history. If you take good history of the patient and you know that the patient has had a seizure, so you would know that this is not a stroke, instead it's Todd's paralysis. Other differential diagnoses include intracranial tumors or infections. In diagnosing a stroke, knowing the symptoms of the patient might give you a hint to which artery is affected. Here's a table to summarize each symptoms according to each artery. We won't go through it. And also, you can check the link in the description for a video done by Dr. Paul Bolin for different stroke syndromes. Now for the investigations for strokes and TIAs, we have immediate or initial investigations. Those are investigations you do as soon as the patient gets to the emergency room. And also you have special investigations. The special investigations will help you to know the exact pathology or the exact mechanism in which the stroke happened. So for the initial investigations, you do a full blood count, and this might tell you that the patient has polycythemia or infection. Now, in polycythemia, the patient has a lot of red blood cells, and a lot of red blood cells will increase the viscosity of the blood, and the patient will be more prone actually to clot formation. You also do renal function and electrolytes because sometimes electrolytes imbalances can give you symptoms similar to stroke. You also do the clotting screens, PTT and PT and INR. Now, it's important to mention that in ischemic strokes, we will use medication. This medication requires certain values to those tests, and we will see that in the upcoming slides. Now, also, you do an erythrocyte sedimentation rate and C-reactive protein. It will tell you if the patient has inflammatory disease, and you also do a thyroid function test for all patients with atrial fibrillation. Now, in hyperthyroidism, actually, patients develop atrial fibrillation. You also do a blood sugar to check for hypoglycemia or if the patient has diabetes. You also do the fasting lipids and a blood culture for endocarditis or any other infection. You also check for autoantibodies and you do coagulation studies in young patients. Why do you actually check for autoantibodies? There are certain conditions. Let's take two examples, like SLE and rheumatoid arthritis. They found that those patients have actually autoantibodies, and those autoantibodies will actually activate the clotting cascade, and eventually the patient will have a clot. And not only that, those inflammatory conditions actually increase the process or accelerate the process of atherosclerosis. You also do an EKG, and this will tell you if the patient has any arrhythmias like atrial fibrillation, ventricular tachycardia, and also myocardial ischemia or infarctions, and if the patient has left ventricular hypertrophy secondary to hypertension. Now that we're done with the initial investigations, we move to the special investigations, and we start by imaging, specifically by the first best initial investigation, which is non-contrast CT. And I will actually tell you why don't we use contrast in this CT. Although actually MRI is the most sensitive method in detecting strokes, we actually use CT because CT is more readily available and you can do it really fast, unlike MRI. And And also, why do we do CT? When you first start doing the CT, you actually want to know or make sure that the patient actually had a stroke. This is the first reason you do CT. The second reason you're doing a CT is that you want to differentiate, or you want to know, does the patient have actually an ischemic stroke or a hemorrhagic stroke? And that is easily done by CT because CT can show you a hemorrhage. Not only that, if you can see here, CT can also identify extraparenchymal hemorrhage and also neoplasm, abscesses, and other conditions that appear like stroke. So if you do a CT for a patient and you do not find hemorrhage, you might find actually a tumor or something else. So you would exclude stroke as a cause of the symptoms of the patient. Now that we talked about the good stuff of CT, let's talk about the downsides of CT. Now, only 75% of infarcts or like ischemic strokes are ever visible on CT. Now, why is that? When you have a patient that had a stroke like 3 hours ago or 4 hours ago, sometimes you might actually get a CT of the patient and you find that the CT is actually normal. So in ischemic strokes, CT does not detect the early changes in those kind of strokes. So even if you take a CT of a patient presenting to you with symptoms of stroke and it was normal, you did not find any hemorrhage, you still do not exclude strokes, because although you can see hemorrhages really fast, ischemic strokes are not that visible. Sometimes they're not visible until 24 to 48 hours, so that's 1 to 2 days. Also, CT will fail to show you small ischemic strokes in the posterior fossa. Now, why is that? The bone covering the cerebellum pons actually will give you errors in the image, or imaging errors. And the other thing, CT will fail to show you small infarcts on the cortical surfaces. The other imaging modality is actually MRI. So in short, MRI is used whenever CT wasn't helpful. So in posterior fossa infarcts, also in small strokes, cortical strokes, and also when the diagnosis is not certain, so MRI is more accurate, it will help you. There's certain sequences of MRI, like T2 sequences, it will detect microhemorrhages. Another sequence of MRI is diffusion weighted imaging, and actually it is the most sensitive modality for diagnosing an acute ischemic infarct. Now, it can also differentiate between acute and chronic infarct, which is another actually good point about this kind of MRI. We also have carotid Doppler. It's basically ultrasound, so it's non-invasive. It's useful in demonstrating internal carotid artery stenosis when you suspect a carotid artery thromboembolism. We also have angiography. So you have CT angiography and MR angiography, which actually uses MRI. So the thing about CT angiography, it's actually invasive. You inject a contrast and you take the images. So it can show you carotid disease and intracranial vascular occlusions. And because it's invasive, actually people are moving towards the second kind of angiography. The second kind of angiography can be done with contrast or without contrast. It is usually non-invasive, and it can show you carotid disease if Doppler was not enough. So if you do Doppler for a patient for the carotids and he cannot see anything, you actually can use this method. And also this method can show you arteriovenous malformations and aneurysms. We talked about the angiography. Now let's take the indications of angiography. So you basically use them in patients with carotid stenosis or carotid disease, in which the non-invasive techniques have failed to clarify the degree of the stenosis. So you did Doppler for a patient with carotid disease, you cannot tell how big is the plaque or how narrowed is the artery. Then you actually go for angiography. The other indication is in patients with unusual etiologies, and the less invasive imaging has not been diagnostic. So for example, in vasculitis, in patients with arteriovenous malformations. Note that in patients with recent completed strokes, angiography should not be considered until 1 to 2 weeks have elapsed. Other techniques include echocardiography. It's done to show you the wall motion in patients with suspected atrial or ventricular embolism, and also Holter monitoring for patients with paroxysmal atrial fibrillation. This is a non-contrast CT picture, and you can see that the patient actually has a subarachnoid hemorrhage or hemorrhage within the ventricles. Now, the important thing to mention here, remember we said we use a non-contrast CT, so if we have used a contrast, we couldn't differentiate, is this a hemorrhage or is this the CSF within the ventricles? So that's why we actually use a non-contrast CT. This is another picture. This is an angiogram showing you an arteriovenous malformation. So this is the feeding artery, this is the nidus, and this is the draining vein. This is another CT showing you an ischemic stroke. So in ischemic strokes, you look for two things. One is the clot, and two is parenchymal changes. So basically, the clot appears as a hyperdense area because the blood is not moving. So here is the clot, as you can see here. So it's more brighter, it's white in appearance. On the other hand, the parenchymal changes consistent with stroke is actually a hypodense area, as you can see here. It's more darker. You also lose the differentiation between the gray and white matter because of the cytotoxic edema, but this picture is not that clear. So as you can see here, this is a hypodense area in the region of the anterior cerebral artery. In those images, you see other strokes. This is in the region of the posterior cerebral artery. This is in the region of the middle cerebral artery. So as you can see here, you don't have the sulci and gyri appearing. You just have a generalized hypodense area. So no features can be seen, unlike here, when you can see the sulci, the gyri, and this is because of the edema we mentioned in the last video, the cytotoxic edema. So you also lose differentiation between the gray and white matter. So here you can see differences in color, but here they're all like the same color. In this slide, I want to show you the difference between CT and diffusion-weighted MRI in acute stroke. So as you can see, the CT, you barely see anything, but when you take a diffusion-weighted MRI, you can see a bright area almost immediately after a stroke on an acute basis. So actually, that's why MRI is more sensitive, so you can see changes in acute matter. I want you to understand, how does diffusion-weighted imaging actually work? So basically, you have a pump on the cells, on the neurons. So the pump usually pushes actually sodium outside, and water follows to the extracellular matter. Now, when the cells are actually dead, those pumps are not working. So you cannot push water outside. So this restriction in fluid movement is what the diffusion-weighted imaging actually detect. So the bright area tells you there is restricted fluid movement to the outside of the cell. Bright area and diffusion-weighted imaging will mean dead tissue. So D with D. In this slide, I want to explain the concept of ischemic penumbra. So if you have a clot right here, as you can see, this whole area is deprived of blood supply. So the tissue starts dying at the core or in the middle. And this dead tissue is surrounded by tissue that is actually hypoperfused, so having less blood supply. This area that is not dead but is ischemic is called the ischemic penumbra. Now, this is actually tissue at risk, so it's not dead, and our main goal actually of treating the patient is to actually save this tissue. So you want to minimize your losses. Losing this is not like losing this. In this slide, we will understand what diffusion-perfusion mismatch means. So basically, we talked about diffusion-weighted imaging. Now, there's something called perfusion-weighted imaging. So it just measures the perfusion of an area. So we basically take those two images together. Perfusion-weighted imaging is actually a type of MRI. So this image will actually show you the areas with restricted perfusion. So as you can see here, this whole area is more whitish in color. So this tells you that this area has restricted perfusion. So the area of restricted perfusion includes the dead area and the penumbra around it. So basically, when you plot those two pictures over each other, so as you can see here, This is the diffusion weighted MRI. So D, dead. This is dead. In perfusion, it takes both areas, the dead and the whole penumbra. So when you plot this picture over this picture, you have this area, which is actually the penumbra, the non-dead area. So this is what we call diffusion-perfusion mismatch. So not each area with low perfusion is dead. This is another picture to explain the concept. So as you can see here, CT, you can barely see anything. On diffusion weighted MRI, you actually see this area of dead tissue. On the perfusion weighted image, you see this whole area. This whole area is actually the perfusion limited area. So when you plot them together, you will end up only with this area dead, and this is your mismatch. This is your mismatch. You want to save this. So starting by the management, let's take the aims. So you first want to manage the stroke on an acute basis in the stroke unit. Then you want to prevent secondary complications like bed sores, DVT. And you also want to prevent the stroke, like in primary prevention, secondary and tertiary prevention, and we will come to that. In management, we start to manage the stroke on an acute basis. So first, you need to check the airway, breathing, and circulation of the patient. You also check the hydration of the patient. Is the patient hydrated? Can he swallow water or not? If he cannot swallow, we give him an IV fluid. An important thing to mention is, we mentioned that patients might get edema after a stroke, and that's why sometimes you need to do fluid restriction for the patient. Sometimes you might give the patient mannitol, which is actually an osmotic diuretic, but you don't want the patient to become dehydrated. Why is that? Because if the patient goes into dehydration, he will become hypovolemic, he'll have hypotension and less perfusion to the brain, and he will actually worsen the infarct. So you also need to pay attention to the nutrition of the patient. So if he cannot swallow, give him an nasogastric tube. Also, throat with medications. If you need to give them IV, give them IV. Now, blood pressure. It's important to mention something about blood pressure. You do not lower the blood pressure. Why is that? Because actually there's a clot and blood is not reaching that area. So it's thought that the high blood pressure is actually keeping that area perfused as much as possible. But you lower it in certain conditions. One of them, if the patient has malignant hypertension. Another condition is hemorrhagic stroke. Third condition includes an ischemic stroke. You want to treat the patient with thrombolytic therapy, and the blood pressure is above 185 over 110. Okay, and the last situation is in an MI. So in a myocardial infarction, actually the high blood pressure is hurting the heart, or it's exhausting the patient more, so you lower the blood pressure. And also for blood glucose, you don't want the patient to go hypo or hyperglycemic, because in treating the patient with thrombolytic treatment, you need the patient to be in a certain glucose level, normal glucose level. And another thing to mention, in hyperglycemia, actually it was found that the infarction is accelerated, or more cells die with hyperglycemia. And in temperature, the same thing was found. When the patient has a high temperature, the process of infarction is actually accelerated. And you also treat pressure areas and incontinence. So then you go to specific treatment according to the type of stroke. So how do you manage a hemorrhagic stroke? First of all, you never give the patient an antiplatelet therapy, because actually clots are good, will stop the bleeding, and if you give them antiplatelet therapy, you will continue on with the bleeding. And then you aggressively manage the blood pressure. This is very important. You do frequent neurological checks for change in the clinical status of the patient. You also find the cause of the bleed. So if it's an arteriovenous malformation, if it's an aneurysm, and then you do surgery like coiling or clipping of an artery. Now let's take ischemic strokes. How do you manage the patient? You actually give the patient thrombolysis. So you want to dissolve the clot. So how do you do that? By giving recombinant tissue plasminogen activator. This actually activates plasminogen. So basically you're activating the cascade that will dissolve a clot. It's best given within 60 minutes after the appearance of symptoms, and it should be administered within 3 hours to 4.5 hours after the appearance of symptoms. Why is it that this period is very important? Research have found that after this period, the chances of this ischemic infarct turning into an hemorrhage actually increases. So if the chances of this infarct becoming an hemorrhage increases, so you don't give something that will dissolve a clot. So the clot actually will stop a bleeding. So if you dissolve it, it will become a hemorrhage more easily. So that's why you give it within this period. And you start counting how many hours. So you count after the appearance of symptoms. So how about if a patient woke up with a stroke? You start counting from the minute he went to sleep. So if he went to sleep like at 8 and he woke up with a stroke like at 1 o'clock. So you count those hours. So okay, 5 hours of symptoms. He's not eligible. So what do you do after thrombolysis? So you actually monitor the patient and you do frequent neurological checks. You manage the blood pressure. You start intravenous mannitol for signs of herniation. So why do you give the patient mannitol? We mentioned for edema. Now the thing is, after you get a stroke, the edema actually peaks within the second to third day, and sometimes it might persist to 7 and even 10 days. So the edema sometimes, if it's very severe, it might cause the herniation by mass effect. It will cause the herniation of the brainstem through foramen magnum. So you give the patient mannitol to actually avoid the herniation, and you also get CT scans to see changes in the clinical status of the patient. And this is a very important point. You don't give thrombolytics or anticoagulants or antiplatelet agents to this patient for the first 24 hours after giving the tissue plasminogen activator. So what happens if the patient does not get thrombolysis? You actually start antiplatelet therapy. You might give aspirin or clopidogrel or dipridamol plus aspirin, and you also manage the blood pressure and you continue with your frequent checks. Indications for thrombolytic treatment. Clinical diagnosis of stroke onset within 3 hours, and also a CT scan showing no hemorrhage, so it's not a hemorrhagic stroke, or edema more than third of the MCA territory. Also age of the patient within 18 years or older, and consent of the patient. Contraindications of thrombolytic treatment include sustained blood pressure over 185 over 110 despite treatment. If the platelets are actually low, you don't give a thrombolytic treatment. Hematocrit also low. The normal is like between 38 to 50, and also a blood glucose level between those two levels, and also use of heparin within the last 48 hours, or prolonged PTT or elevated INR, because you don't want the patient to bleed. And also rapidly improving symptoms, so like in TIA, prior stroke or head injury within 3 months prior intracranial hemorrhage. So the thing is, if the patient had any injury or any surgery recently, there are areas that might have bled and then you had a clot, and that clot is the thing actually stopping that bleeding. So if you give the patient thrombolysis, you're actually increasing the chances of that other clot being dissolved, and the patient might bleed from somewhere else. And major surgery in the preceding 14 days, we actually just said the reason. It's the same reason as in head injury. And also minor stroke symptoms and gastrointestinal bleeding in the preceding 21 days, and recent myocardial infarction, or stroke. For prevention, first we'll take primary prevention. Now, primary prevention actually means that you want to prevent a stroke before it happens. So how do you do that? By controlling hypertension, do not smoke cigarettes, control diabetes, control dyslipidemia, and also in atrial fibrillation, you give anticoagulants to patients. So just a point, you don't give anticoagulants as a primary prevention except in special cases, like here, as you can see, atrial fibrillation. And also diet and nutrition. So you decrease the sodium to maintain like good blood pressure, and also physical activity. Secondary prevention. What is secondary prevention? Secondary prevention is when a patient gets a stroke, but you don't want it to happen again. So you give the patient antiplatelet medications to decrease the risk of thrombus formation. So NICE actually recommends clopidogrel, and if the patient is intolerant, you give him aspirin and dipridamol. And if the patient is intolerant to aspirin dipridamol, you give him dipridamol alone. Now, risk factor management is also a way of secondary prevention. So you tell the patient to stop smoking. You give him statins for cholesterol. You control his diabetes. You also put a patient on a diet and let him exercise. And you also have to remove or treat the embolic source. And that's by anticoagulation. So if the patient had a previous clot, you give him anticoagulation to minimize chances of having a clot. So for example, patients with atrial fibrillation, you give them anticoagulation. Patients with heart failure and a dilated ventricle, you give them anticoagulation. So you don't give anticoagulation for anyone. And also, antibiotics. When do you give antibiotics? If the patient had endocarditis. Also do endarterectomy for patients with a carotid stenosis or a carotid plaque. That has a criteria, you can go through it. Now you can note that anticoagulation is indicated for cardiac emboli, but only once a cerebral hemorrhage has been excluded, and not for at least 7 days after an acute event to prevent a hemorrhagic infarct. And at last, tertiary prevention. So tertiary prevention actually means rehabilitation, so you should begin that as soon as possible. We won't go into details. Those are the references I used. Many of the information in the slides are actually copied from those references, so as I found them the best references for this topic. If you have any questions, comments, or suggestions, contact this email. Thank you and have a nice day.